Hi, my name is Clifford Hudis, and I am the CEO of the American Society of Clinical Oncology, as well as the host of the ASCO in Action podcast. About twice a month, I interview thought leaders in healthcare and experts in oncology, and we provide analysis and commentary on a wide range of cancer policy and practice issues. You can find the ASCO in Action podcast on Apple Podcasts or wherever you are listening to this show. And you can find all 9 of ASCO's podcasts, which cover a wide range of educational and scientific content and offer enriching insight into the world of cancer care at podcast.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series, brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all of the shows, including this one, at podcast.asco.org. My name is Shannon McKernan, and today I'm interviewing Dr. Kimberly Allison from Stanford University School of Medicine and Dr. Antonio Wolf from Johns Hopkins University, expert panel co-chairs and authors on estrogen and progesterone receptor testing in breast cancer, ASCO CAP Guideline Update. Thank you for being here today, Dr. Allison and Dr. Wolf.
So glad to be here. Thank you.
Thank you for having me.
So first, can you give us a general overview of this guideline and its history?
So maybe I can start as a medical oncologist, and I think this guideline highlights the importance of multidisciplinary work. I think we have historically used estrogen receptor and progesterone receptor testing in a variety of ways. We can use it to help classify the breast cancer and figure out the optimal treatment pathway. Before we had HER2, and we essentially classified tumors in terms of being ER positive and ER negative. And with the availability of adjuvant endocrine therapy, this essentially became critical to go one way or another. It also provides some prognostic information. We know that patients with ER negative disease and essentially triple negative disease have a higher risk of recurrence early on. Patients with ER positive disease have a residual risk of recurrence later on. In some cases, for patients with advanced disease who are diagnosed with cancer in an advanced stage, the detection of ER expression can further help with identifying the potential origin of a metastatic cancer. So therefore, in the past, these assays could have been used primarily to aid in the anatomic diagnosis, but gradually biomarkers in breast cancer such as ER, PGR, and HER2 can become, in essence, the sole determinant of treatment selection. And therefore, accuracy became such a critical issue. And I think this is where the role of the pathologist have become even more critical than before. So let me pass this to Dr. Allison.
Yes. So thank you, Antonio. I think from a pathologist perspective, hormone receptor testing, ER testing in particular in breast cancer, was really one of pathology's first predictive markers. And so it was really important to, get together with ASCO and CAP to get standards for the first time set back in 2010. There was a lot of variability at that time in what labs were using for a positive result for estrogen receptor. And there was essentially no proficiency testing for labs, no way to know if your lab was giving similar results to other labs. Since then, there's been dramatic improvements, I think, in monitoring the performance and reducing interlab variability in ER testing. A minor amount of variability continues to exist, and that sort of emphasizes for us the need to continue monitoring and attending to laboratory performance for this predictive test. So historically, this was a really critical moment in pathology predictive testing to set standards for the first time, similar to HER2, which came just before the ER guidelines. So, the standards that we had in the 2010 guideline mostly have been reaffirmed in the update. But I think this time around, we're really focusing in on some of the questions raised about what to do with cases that have lower levels of estrogen receptor expression and make specific recommendations around those.
I would like to add one other important point to what Kim just mentioned. From a historical standpoint, what is interesting is that the joint interest by ASCO and CAP to work together initially came with the findings from the first generation of adjuvant trastuzumab trials in patients with HER2 positive disease, and the recognition that the inaccuracy of HER2 TACI was very high, in some cases approaching, in terms of false positives early on, almost as high as 30% of cases being false positive. And we saw a significant improvement in the quality of HER2 testing quite quickly. And that actually served as the impetus for us to go back 20 years and recognize that actually we had an issue with an assay we had been using for much longer, which was ER and secondarily PGR. So it was fascinating to see that the impetus for us to do the first guideline on ER and PGR actually came from our experience and success with the guideline on HER2 testing.
And so for our listeners who have not yet read the guideline, what are the key recommendations of this guideline update?
So, as I mentioned, a lot of the update really reaffirms most aspects of the original 2010 guidelines, and we really are focused in on what to do with low ER positive cases. So we looked at the data largely based on meta-analysis of endocrine therapy trials, and maybe Antonio can comment on that data overall. But it looked to us that there wasn't a reason to change the threshold from 1% being the positive threshold. So cases with 1 to 100% estrogen receptor expression in an invasive breast cancer would be considered ER positive for the purposes of considering a patient eligible for endocrine therapy. But what our update looks at is the data and how limited it is on the lower estrogen receptor positive cancers. So 1 to 10% being the most common definition of a low ER positive. These are not common cases. About 2 to 3% of invasive breast cancers are in that range of expression, but they really cause a lot of controversy in terms of treatment recommendations. So the data that we looked at helped affirm that that group probably does benefit from endocrine therapy and so should be considered positive. But there are also data that supports that this group is often similar in other ways to ER negative cancers. They're often higher grade. They would often profile by gene expression as a more basal-like cancer and maybe warrant consideration for overall treatment pathway as an ER negative cancer. However, they should be considered ER positive for the purposes of considering endocrine therapy. So what the guideline update recommends is that we acknowledge this is a limited data zone. We report these cases with 1 to 10% ER expression as low positive and include a comment on those cases that acknowledges the limited data about the overall benefit, but that currently they suggest possible benefit. So patients are considered eligible for treatment. And that there's data that this group may be actually quite heterogeneous in behavior and biology and have gene expression profiles more similar to ER negative cancers. One of the other aspects that we were interested in is in these low ER positives and in ER negative cancers, so ones with less than 1% staining or 0% staining, that we want to really focus in and ensure labs are producing a valid result in those settings. The vast majority of cancers do test strong positive for ER, but we really had our most concern about the quality of testing in the negative or low level expression. So one of our other recommendations is to ensure the validity of those low positive or negative results in cases with 0 to 10% estrogen expression. Labs should develop a standard operating procedure to evaluate those in another set of steps to make sure that that result is reproducible and accurate, and that those additional steps should include things like reporting and evaluating your internal and external controls to make sure that that stain worked on that particular sample, as well as correlating with the histology, for example, a low-grade invasive ductal carcinoma or invasive lobular carcinoma that's grade 1 really should have high ER expression. That's the expected result. And we include a table in our guideline update that helps with correlations with histology. And then the labs should develop other standard operating procedures, like having a second review of those cases to ensure that that lab result is reproducible in terms of reading it and interpreting it by all the pathologists in your group. So that's the recommendation to help ensure that those cases are reported as accurately as possible, but also acknowledging that they are a bit of a gray zone. The other update aspects that we address are in our clinical questions 3 and 4. So those address that validated IHC immunohistochemistry is still the recommended standard test for predicting benefit from endocrine therapy in invasive breast cancers. We looked at data for other tests, and a lot of these trials were done many decades ago now that looked at this question. So it's hard to come up with new assays that can replace that data or supplement that data. But luckily, immunohistochemistry is still a very inexpensive, highly accurate screening test that has become routine practice that is still recommended as the primary screening test for this purpose. And then our last question and update was in reference to DCIS, which supported continuing to recommend estrogen receptor as a test to use for determining potential benefit of endocrine therapies to reduce future risk of breast cancer in DCIS patients, and PR testing was considered optional in our update for DCIS. I think that's the main points I was going to bring up for the updates. Any highlights or feedback you'd add to that, Antonio?
One important aspect to complement all that is being discussed today is for us to realize that testing as done today, primarily with immunohistochemistry, which is the most validated and standardized test we use, the evidence for benefit from endocrine therapy come from clinical trials done in the 70s and 80s and perhaps some in early 90s with ligand binding assay, where essentially we were measuring concentrations of protein. So it became clear that the clinical benefit from anti-estrogen was observed when we had a concentration of ER above 10 femtomoles of ER per milligram of protein, and for the most part, or even higher than that at 20 femtomoles. But for the most part, when we transitioned from ligand binding assays, which were more cumbersome and often done in central labs, to routine immunohistochemistry done in the community and essentially in any lab, those were assay concordance studies using imperfect materials that had been preserved from older clinical trials. So we now have a sense that the ER expression in terms of immunohistochemistry of 1% corresponds to a concentration of ER in the ligand binding assays of about 10 femtomoles per milligram of protein or higher. But we actually have some uncertainty about the actual benefit. With LBA assays, we see a linear dose response in terms of concentration of ER and benefit from therapy. We see less of that with the immunohistochemistry. We see clear-cut benefit from anti-estrogens above IHC 10%, and potentially a much lesser benefit between N1 and 10%. but we just did not feel that we were ready to abandon the option of using anti-estrogens therapy for those patients with IHC 1 to 10%. And consequently, we felt we needed to continue to make the recommendation to call them positive, but we created the category where we designate them as low positive simply to highlight that the likelihood of benefit is likely to be a lot smaller, and those patients should be considered for additional therapy, in many cases, chemotherapy.
And so why is this guideline so important, and how will it change practice for both oncologists and pathologists?
So maybe I'll start. And I think that it's not going to change what we do. I think it's going to reaffirm what we have been doing for a long time, but especially in the last 10 years, the importance of accuracy and high quality testing. And number one, making sure we have the most accurate testing possible, but also acknowledging that we do have a subset of patients with a lower likelihood of potential benefit, and those patients should be considered for potentially additional therapy in patients with ER low or ER positive high-grade tumors that tend to have lower concentrations or expression of ER. These patients will be considered for chemotherapy. And then we have the scenario in clinical research where a lot of clinical trials ask the question of whether patients with ER 1 to 9% or ER 1 to 10% should be considered ER negative, and we did not think we should do that. If you're talking about clinical trials testing chemotherapies, cytotoxic agents, these cancers tend to be more high proliferative, so the responsiveness to chemotherapy may be quite similar in an ER very low and in a triple negative cancer. But for a lot of triple negative trials that are using targeted agents, we did not think that by default an ER IHC 0 and an ER IHC 5% should be considered the same, and that those patients should be entered equally on a clinical trial testing new targeted agents that are not chemotherapy. So if nothing else, I think it's just going to reinforce what we do and allow us to be even more careful with the designation that we give to patients in terms of tumor phenotype.
I agree. I think that it's reaffirming our current standards and standards of practice in laboratory testing for ER. It's also reaffirming the collaboration with clinicians and pathologists to be aware of the borderline zones and when results are close to a threshold. Also, when results are unusual or discordant, that the pathologists and the oncologists work together to explain and resolve those findings. And, I think it'll really help pathologists focus in on the area that we really need to pay attention to, and in the low positive or the negative cases, making sure those are as accurate as possible, and that our controls worked well, and that we've got our assays calibrated appropriately to pick those low positive cases up.
And so finally, how will these guideline recommendations affect patients?
So I would say that everything that we just said in response to the previous question, using a lot of technical terms, ultimately for patients translate into higher quality testing, greater accuracy, greater chances, likelihood that we are going to be able to make the right diagnosis of the right phenotype, so that we can potentially discuss with patients how to make the most appropriate treatment recommendations to ensure that the patients receive the right treatment for the right diagnosis at the right time. So it's ultimately improving quality of care, if nothing else.
Well said, Antonio. I think for patients, it should be comforting to know that this is such a reproducible, valuable test that really informs individualized treatment pathways for breast cancer patients. And I think it's important to know that there are gray zones and borderline results that patients should be aware of, because decision-making is not as clear cut always in those settings. And that's a possibility. That isn't a right or wrong answer that has occurred, but it's that you're in the borderline zone for a particular cancer.
Great. Thank you both for your work on this important guideline and for taking your time today to give us an overview, Dr. Allison and Dr. Wolf.
Thank you, Shannon.
So happy to do this. Thank you very much for the opportunity.
And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. To read the full guideline, go to www.asco.org/breast-cancer-guidelines. And if you've enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.